Okay, everybody, good evening and welcome to the Brent Health Matters Hour on the Beat. My name is Douglas Jakin and I am going to be hosting today's discussion. If you are just joining us, this is a regular show that we do every last Wednesday of the month where we bring together amazing experts to talk about health matters because we believe that health is wealth. And forget what you thought before, that ignorance is bliss. It's not. Ignorance actually can be quite fatal. So today we're going to be discussing women's health, and the core focus will be on endometriosis. Sounds a bit of a tongue twister, so we're going to delve into it. I have with me today Mr. Amer Razar. Mr. Amer Razar, oh my God, he is a minimal access and robotic surgeon. He's a clinical director of women's services gynecology at Chelsea and Westminster Hospital. He's also the lead consultant on endometriosis and a senior lecturer at Imperial College. Mr. Razar, it's a pleasure having you on the show.
Very much. Thank you. Thanks, Douglas, for inviting.
Fantastic. I also have Christina, who is an endometriosis and fibroids clinical nurse specialist at Imperial College at the Healthcare NHS Trust. Hi, Christina.
Thank you so much. Good evening, everyone. Thank you.
You're welcome. Good to have you on. And we have the lovely Manuela Capraro, but I'm going to call her Manu for the rest of the show. She's given me permission, by the way. She is an artist who works in the bar and has experience of endometriosis. Hi, Manu. How are you?
Hello, everyone. Yeah, I'm fine. Yeah, thank you so much for inviting me today.
You are so welcome. You're so welcome. And I'm so excited to have you lovely people on the show. I'm so glad that we can have this conversation. So let's just jump into it. First of all, for anybody who's listening, if you have any comments you want to send in, please, you can always send a tweet at the beat 1036 and tag Brent Hen Council, and we will see if we can pick up those questions as well. Okay. So I will start my question this evening with Mr. Amer Razar. Doc, can you, Mr. Amer, could you just quickly tell me what endometriosis is all about? Because I Googled the definition of endometriosis, and what Google kind of explained is that it's a condition where tissue similar to the lining of the womb grows in places such as the ovaries and fallopian tubes. But I want to hear from a clinical point of view what endometriosis is. Do you mind telling us?
Thank you very much, Douglas, first of all, inviting me to talk about this very, very important topic. Endometriosis actually is quite a common condition present in about 15% of the women, all the way from young age to up to 50. And this is a disease in which you correctly try to put it together, that the endometrial gland, which are inside the uterine cavity, these are the endometrial glands which bleed every month as a period. Some of these endometrial glands through the fallopian tube go inside the abdomen, and wherever they go, especially around the uterus area, they produce stickiness and scarring, and the stickiness and scarring into the fallopian tube, ovaries, bowel, bladder, then gives lots of symptoms. But that's one way of putting endometriosis. We are still learning more about endometriosis. So where we can say that the endometrial glands outside the uterus are called endometriosis, causing pelvic pain, scarring, and adhesions. On the same token, there are other theories as well, such as there are some inflammatory markers, inflammatory cells, which can lead to endometriosis. There are some genetic factors have been implemented along with some immunological cells. Immunological cells are our body has a lot of immune cells. Sometimes they can become active. So what I'm trying to say is there are different ways we can explain how endometriosis develops and then lead on to cause pelvic pain. And the reason the people will get symptoms is because this stickiness and scarring, because of the endometrial glands growing outside the uterus, will involve different structures, and structures get inflamed, stuck together, then they bring out the pain, and the symptom will be reflective of the organ which is involved in this problem.
Christina, you are a specialist. You are also an endometriosis and fibroids clinical specialist.
Yeah.
Talk to us real quick about the impact that this has on women, endometriosis.
Oh, well, where to begin? I feel, as Mr. Raza was explaining, endometriosis is a chronic recurrent disease, so has a high incidence of recurrence, which means after it's treated, it can always come back. It's not definitive treatments. And if you think about the fact that it takes up to 7 to 8 years for a woman to get diagnosed with endometriosis, and the journey that these women embark from, developing the symptoms, having to go back clinician after clinician after clinician, so to go for so many years to finally get a diagnosis and get the appropriate treatment, you wouldn't imagine the impact on the quality of life, first of all, for all these women, and the mental health and the way that they feel in regards to the healthcare system that they've been put through, and all this, all this process they have to go through. The impact is huge. Also, you have to consider that the amount of patients that have endometriosis, and Mr. Raza was saying, is almost similar to the number of people having diabetes in the UK today. The numbers are almost the same. It's 1.5 million women in the UK nowadays are affected by endometriosis. And that has huge impact on the quality of life, the ability to work. It's a debilitating disease. The fertility as well. It doesn't necessarily mean that all the patients that have endometriosis, they do have fertility problems, but it's been shown that up to 50% of the patients that go through fertility treatment, they also have been found to have endometriosis. And most of the time, the finding is incidental on the fact that they're going through investigation for that infertility, and they find out that they're having endometriosis as well. So that the range of impacts, it just goes from, it's a 360 degrees, and it's huge. It's absolutely huge.
I want to bring Manu into this conversation. Manu has lived in experiences from endometriosis. Manu, do you mind telling us a little bit about yourself and the journey that you had to go through with endometriosis, dealing with endometriosis?
So listening to Christina and what she actually said just a few seconds ago is just remind me, how tough is my life, not just my life, but all the women that they have endometriosis. The journey starts long time ago. So it's not something that you have, like diabetes, it's not something that you have. I'm talking about diabetes type 1, of course.
Right.
It's not something that comes up like, oh, suddenly one day you feel like, oh, weird, something is going on. It's not like that. So the first symptoms that I had, it goes back to when I was 10 years old, and it was crucial because of course that was the time when I had my first period, and it was exactly when I finished my primary schools. So we're talking about a very young little child, because I would like to tell me to call me like a child at that time. And I still remember I was actually planning to go, we as a family, we were planning to go to the beach. We were planning to go to the seaside, and it was summertime. And I felt like I was in pain, completely in pain. I had tummy ache. I felt like sick. But my mom, she knew that I had that symptoms even before I had my period. And she kind of like tried not believe in what I was saying. And so we went to the seaside. So we went to the beach, and imagine that lovely young little girl going to, jumping out, in and out from the water, beating with the hot weather as well, and feeling completely unwell. It was a disaster. And in fact, when I went back home, I realized that I had my first period, and it was so crucial. I was in pain for the whole day, and since then my life was a disaster. So I had my tummy ache. I had to call my mom all the time. I went to school, so it was quite often. But what is quite weird is people, they don't believe in you. They think you want to miss school, or you want to miss, doing your homework or things like that. But it's not actually that. I was really literally in pain. And until I got into my teenagers, and it was probably the worst time ever in my life. Been studying, it's been really difficult as well, because it's not just about the pain, it's about the pain that affects your brain as well. So you can't really be focused on to things that you're going to do. Mentally, you feel exhausted. So it's kind of like that. Of course, you have one day which is better and one day which is completely, you just need to lay down in bed because you can't move. Literally, you can't move because you got pain all over your muscles. That's my experience, of course. Yeah.
Man, I hope you don't mind me delving a little deep into, because I'm assuming we have listeners who are listening who probably don't even know what this is about, right? Because there is always the assumption that before your period comes, you are to feel some pain, right? I have a young daughter, and she complains about that as well whenever her period comes. But there's a likelihood that young girls or women could mistake that for the coming of their period. So if you don't mind me just asking you, like, this pain, was it a daily was it like a daily occurrence?
Right.
Could you just elaborate a bit more on that?
Absolutely. So the pain that you feel is not just during your period, it's before and during and a little bit after as well. So that's my experience. So the pain that you have is not just a normal period, which every woman, probably women, they have, but it's not like having cramps or feeling like you need to go to the loo every second, or if you eat something that your stomach doesn't want, you have a really bad reaction as well. So it's the cramp that it doesn't let you to go out, it doesn't let you to do anything, so it just let you to stay in bed.
It renders you immobile pretty much, right? Like you can't move freely. Is that what you're saying?
Yeah, exactly, because the pain you have, it's all over your ovary and all over your stomach as well, but affect your muscle. That I can talk about myself. It does affect my muscles as well, and yeah. So basically, it's about physically you can't really do much. Again, especially on that particular days when you have your period, but even a week before you get into it. So it's basically you got pain all over your legs as well, so your back, mainly my muscles as well. So and it's something that you need to treat with painkillers, because otherwise you can't really cope.
That's right. Mr. Imran, I'd like to bring you in here real quick, because Manu had kind of just teed us up on that, because that was going to be my next question. When you come across a patient who is suffering from these pains, how do you help them? What's the treatment there?
I think Manu has painted a very sad and painful picture, and very correct picture. Christina will recognize this picture when we see people in our clinics, and it's exactly the way we are presented, that it starts from very young, early age, and missing schools, missing exams, and everything becomes tough. And when a young girl is going through such a challenging part of their life, where education, relationships, everything is so important, and then physical activity and game, and this endometriosis can absolutely make everything so difficult. So thank you, Manu, for presenting such a good picture of how difficult this situation can be. So I think I will just paint the picture in an easier word, that how it develops gradually. Endometriosis, when it starts even at a young age, these glands which come outside the uterus, they start scarring. And the first thing is the people start to, even though it can present in a different ways in different people, there's no fixed way, but the most common way of presenting it, the pain starts a couple of days before the period, gets worse during the period, and then as the period goes away, the pain starts to get better and things start to normality. This is when it starts. This is when disease now starts to happen and progress. As this endometriosis, this tissue which is outside the uterus now, start to stick with the bowel, start to stick with the bladder, then this cyclical nature of the period, cyclical means that we get periods every month, that's a cycle. But this cyclical nature that my pain comes when my period comes, it start to disappear. And then pain almost becomes a continuous phenomenon. It becomes like an everyday thing. It gets worse when the period comes. It gets worse when some other events happen. But actually pain becomes everyday thing. So it changes from cyclical nature to acyclical nature. So that's number one. Secondly, as this endometriosis grow behind the uterus, that's the most common place to be, it involves the ovaries. If it involves the ovaries, they swell up. They are small balls and ovaries, and they start to swell up. As they swell up, they also become very painful. And as it grows toward the bowel, then passing stools become painful. Some blood start to come with passing stools, and it then involves the bladder area. Then even passing urine can become painful. So you can now see how a progressive disease from a very early stage start to grow from one area to the other area and impacts the whole pelvic area. And then the other challenges, if this was only pain with area, that's one thing, but it affects the brain, as Manu very correctly said. Actually, it is a huge psychological stress, depression, anxiety, not able to sleep, and peer pressure. Your friends, young friends all around you, either going for games or whatever they're doing, it's a peer pressure that you are suffering with that pain and you cannot be as normal as they can be. So it's a very big challenge. Now, for me as a clinician in the clinic, it's a very important thing. And everybody who's listening to me, either patients or even maybe clinician, it's very important to listen to patient first of all. Just sit back and listen. That's what we need to do. If we listen for 2, 3, 4 minutes even, without interruption, we will get the story. Christina very correctly said, and that's the biggest challenge we all have in medical world. It takes 7 to 8 years for someone to get through a GP and seeing one specialist and second specialist to get to some endometriosis center where they can be properly diagnosed, managed in a multidisciplinary way, which I'll come later on. So it's a challenging journey for the 6, 7, 8 years. So whoever the clinicians are, and myself is, we have to listen. If we listen to the whole story, we will absolutely understand what's going on. That's number one. So when I'm listening to their pelvic pain, cyclical nature, acyclical nature, and then pain with intercourse, that's a big problem because it involves the lower area and scarring, adhesion, lower area. Intercourse become painful. During the periods, passing stools can become painful. Blood can start come. So these are very telltale signs of endometriosis. However, the challenge also is that while somebody is having problem with the bowel, there could be other problems as well. It could be bowel problem like inflammatory bowel disease, Crohn's disease, irritable bowel syndrome. It could be a problem with bladder as well. So clinician has to then make sure to have a differential diagnosis, or in our language, a list of things which can be happening and ruling them out to get to the right diagnosis that, yes, I'm not missing any bowel problem, bladder problem, some problem with the muscles. It is endometriosis. So it's a matter of taking a good history, doing a good examination. And then other thing we ask for ultrasound scan. Ultrasound scan is also a very good tool in our hands to be able to see the pelvis on this TV screen, on which we can see what's going on inside. It's an investigation which can be done in the clinic setting by a radiographer or by a clinician. So a good history, examination, ultrasound scan can help us to narrow it down to endometriosis and then take the next steps for their treatment.
And just listening to all of this, yeah. First of all, Manu, I want to reiterate what Mr. Razak had said earlier on. Thank you so much for painting that picture for us, right? And you know, I have a deep felt sympathy and for anyone who's going through this, because it must be pretty difficult. Christina, I want to bring you in here because you're also a fibroid specialist, right? And earlier on, you had mentioned that it kind of that the endometriosis manifests differently in women. Yeah. Could you go down that rabbit hole a little bit and tell us how that also leads to fibroid, if it does?
Well, you mean in relation whether there is a correlation between fibroids and endometriosis? And
endometriosis, yes. Is there
well, first of all, fibroids is when it's benign growth within the uterus. It can be inside the uterus, in the lining of the womb, or outside the uterus. And in some way, they can simulate the symptoms of endometriosis, some of them which being heavy menstrual bleeding, painful periods, pressure symptoms in the bladder and the bowel, because obviously this little mass of tissues growing in the uterus, they can then start pushing on all the organs around, and that can cause a series of pressure symptoms, as we call them. Whether there is correlation between endometriosis and a woman having endometriosis because has fibroids, or have fibroids because she has endometriosis, that, to my knowledge, there's no link. And maybe Mr. Raza can link in and just, explain if he knows better. Most likely he knows much better than me. But it's been found that many women that they come through our services, at least the women that I see, that they have a degree of endometriosis. Some of them, they also have fibroids, and some women that sometimes they come to the clinics for fibroids, and then we do this scanning, we do these ultrasounds or the MRI to measure these fibroids and see how big they are and where they are, and whether we can remove them surgically, or we do other treatments to make them smaller and all sorts. And then we found that actually there is some sort of degree of endometriosis there. So you sit in a team of, on a multidisciplinary team for the fibroids team, and then you get the patient be referred across to this endometriosis service, because now the patient's being found to also have endometriosis. And is this now the reason why the patient is experiencing some symptoms? So there is not a really clear cut between the two, because sometimes the symptoms can overlap, and the impact on the quality of life can be similar. But I have to say, it's much easier to see a fibroid, and you can palpate a fibroid if it's an expert clinician that does a physical examination. They can actually touch the belly of the woman, and they can determine whether there is fibroids and whether the uterus is enlarged or not, whether you can't do that with endometriosis. So it's much more difficult to make a diagnosis. Whether with fibroids, I find that it's easier in a way, because you can actually feel it, you can see it. Sometimes endometriosis is not a very nice disease. Is really difficult to manage, and as I said, it takes up to 7 to 8 years, and that's something just to get diagnosis, to understand whether there is a disease or not, and that tells you a lot about the implication of the disease and how difficult it can be for the clinician as well.
Right.
And the other thing is that most of the time I found the patient that come through the service, they go through such a difficult time with the different clinicians. As Mrs. Raza says, sometimes all they need is just somebody to listen to, and if you really give them that time, they become disheartened, they have no confidence, they have no hope, they don't believe in you as a clinician, as a service. After they've gone through such a hopeful time, you could actually do something for them. So it's really difficult to gain that trust, and to make sure that they actually trust you and believe you. And you need to really allow them to feel the way they feel, and give them that space they need, and feel that their feelings and the way the experience has been really validated, because it's really disheartening. And I mean, Manuela, she's given us the sample picture. You see that all the time, and the patients, they come in tears and they actually can't believe it, and it's awful. It's absolutely awful, and it's heartbreaking. Yeah, absolutely.
Very much so. I mean, I can't even imagine the pain. Manu, first of all, I want to thank you once again for actually coming to talk to us about this. So how have you coped with it? Like, what are some of the steps or advice that you can give anyone who is just discovering now that they have endometriosis and are having to deal with it? How have you coped with it? What were your mechanisms?
Right. First of all, what I would like to say to everyone, and this is actually what I did myself. So speak up loudly and ask for help, because what we don't need to do is to suffer in silence,
right?
Because it's something that it really exists, and because pain is valid, and we deserve support for it. And so please, for everyone who is listening over there, don't give up. So you might want to be listened for the first time, but if you reach out to whatever community or whatever you want to go to talk to, be ready to fight for the care of your reserve, because that's what I did. Actually, going back to how long it's going to take before you can be diagnosed, it takes me 40 years. 40.
What?
Yes. And it was by accident.
Wow.
What happened? Yeah. What happened was that, so I start to have problem with fertility, and what we had to do, me and my partner, go through the infertility service through the NHS. The first treatment that they gave me was pills called Clomid. So probably the Christina and the doctor, they knows exactly what I'm talking about. And since I start my journey into it, I had a severe pain. After 2 or 3 weeks, I start the treatment. And since then, I went back to the gynae and I said to him, listen, I think something is going on wrong. So I feel such a very, very dramatic pain. So what's going on? And he say, no, it's fine, everything is fine. So just keep going and just carry on to do your treatment. But the pain was going on for a year. So it's almost a year, sorry, for about, since I started the treatment, it was 3 months. The pain was going on and going on. So I just realized that something was going on wrongly. So, and I looked at the science effects about Clomid, and he said, please stop taking it because it could be a sign of endometriosis. And then it was bang, right, okay, there it is. And luckily and certainly, I have one of my best friends that she suffered from endometriosis, and she was talking to me about that. Because while I was explaining to her, listen, I got this problem, I'm in pain, so blah, 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 she said, it will probably be endometriosis. So I went straight away to the gynae and I said, can we stop using Clomid? We might need to go with a different treatment. No, it won't be. It's not Clomid, just keep going. Because I'm quite strict and I'm quite determined as well. So I said, I'm not going to go ahead with that. So what I'm going to do now, please, you need to do a laparoscopy, which I was going through anyway, because I had a cyst that it has to be removed. And in fact, I had the laparoscopy, and they found a tissue of endometriosis outside of my womb, my uterus. And so I was about 40 years old when I found out, what was going on.
Wow.
And since then, I didn't want to go ahead with my treatment. I didn't want to go with an IVF as well, because I know how terrible it can be for people like myself. Because of course you need to go with another type of treatment, which is more or less the same. It won't be Clomid, but it's still pills anyway. So they have to treat your hormones in somehow. And I didn't want to go through it. But this step is horrible as well, because you need to, what I think, if it was diagnosed before, let's talking about 10 years before, I wouldn't get into that kind of decision of not having kids in my life anymore. So they might had another way to make me feel like getting pregnant and having kids. But that's the sad part of my life, which I love kids. I look after kids. So I work alongside kids, but I cannot have, my own one.
Right.
Because of the age as well. I'm 43 years old now. So it's not easy anymore.
Yeah.
So that's, yeah.
Well, can I just say something real quick? I don't think you look 43. So,
Oh, thank you.
God has blessed you with you're beautiful.
44.
You definitely don't look 43 or 44. So at least that's one thing. Doc, I want to ask you, Manu has just rightfully stated that obviously this has led to infertility in her case. Is that as a result of how long it took her to discover it? Like if endometriosis is discovered earlier, can it be cured?
Very, very, very good question, Douglas. And I'll pick this question in 2 ways.
Right.
One is fertility. I'll come to. That's a very important thing. Such an important thing. Is one of the most important thing in one of the women's life. Not everyone. Everybody has different priorities, but it's such an important thing.
Right.
So number one, a study was done in Edinburgh, Professor Andrew Hall, and they tried to look at it, that how endometriosis can have an impact on the life of a young woman or any woman. They saw that if any woman who has no endometriosis, just a normal school life, normal university, gets a job, gets into a relationship, have children, her graph starting from 0 when she was born, and then goes all the way nicely up, like you can imagine a nice curve going up. Then they studied all type of patients who have no endometriosis, who have endometriosis but diagnosed early on, treated, sorted, that second group, and third cohort was where it was not diagnosed, it went on and on for years, and what impact. So there are 3 different groups they came up with. So first group, normal, you look at the graph, it goes up very nicely. The group which has endometriosis and was not diagnosed with endometriosis went on to have until long, and sadly, like Manu at 40 years, she was diagnosed with it. They saw the graph of that life going in, just went up, struggled, and then down, and it just kind of hovering on the lower lines because they struggled with everything what came along their life. And obviously endometriosis can range from mild disease to very severe disease. I don't want to say everybody has the same thing, but they're talking about complex cases here.
Right.
The third group was who have endometriosis, but was diagnosed on time, treated properly in a multidisciplinary care, and they help everything from psychological support to physiotherapy, taking the endometriosis out surgically, and helping fertility, whatever help they needed at a very early stage. Their graph, actually, quality of life graph we're talking about, almost was closer to someone who had no endometriosis. So this tells us that early diagnosis and knowing about it can improve hugely the quality of life. So you are that answering that how progressive it is. And if it's absolutely, if it's diagnosed early, it has huge implication, because one thing, again, I'm sure that Christina will say that as well, that when we see people in the clinic, the moment you say to them that you have endometriosis, they start to cry, because there's something nobody believed on them for so many years, even sadly parents, because they didn't know aunt had a pain and sister had a pain and flying is just a normal thing. But that's not right. It's not a normal thing. So all those young girls and mothers who are listening to me at this time and listening to this program, I would say to them, if you have pain, if you have a pelvic pain, make a pain diary. Write it down every month, that when your period came, when you got the pain, score your pain yourself from 0 to 10. Write it down in the diary. 0, no pain. 10, so bad, you can't go to school. You're lying in the bed with a one bottle in your tummy. You're taking paracetamol. Score yourself 6 out of 10, 7 out of 10, and make this diary. So when you go to your doctor with all these symptoms, which we have gone through already now, that go to say, look, I've got this diary with me. My pain is this. Severity is this. I think I may have endometriosis. No, you may not have endometriosis. You may have a different problem. Let's not miss the elephant in the room, which is affecting 15% of our young women. And let's not miss it. And as Manu said, I'm quite perseverant. I said, look, I got to get it done. You need that attitude, Sartab, I'm afraid, because doctors are, I'm not blaming them, but sometimes they do not get to the point that what may be causing the problem. But once you persevere, once you show them that, look, I'm keeping a diary here, these are my symptoms, they will listen, and they will try to help you. And if they do not know themselves, they should be referring you to someone else. Not every doctor. I don't know anything about every disease in gynecology or so if they do not know, that's okay. They may should refer you to someone else who knows. So getting the right help is absolutely key, and getting the right help early on is absolutely key. Now, coming to your fertility question. Fertility is a big problem. Let's think how the fertility works. That when somebody gets pregnant, we have sperms which goes and fertilizes the egg through the fallopian tube. Now, this whole area actually can be full of endometriosis. Endometrial glands can go into the ovaries which have thousands of eggs actually. It creates this old blood brown discharge within the ovary, and they swell up. Quality of eggs and follicle goes down. The fallopian tube through which they travel, it can lead to adhesions and scarring inside the tube, and tube is microscopic. This sperm has to go through microscopic, it gets blocked. Outside the tube and the ovary, everything starts to stick together. So these sperms cannot swim, the eggs cannot fertilize. Even if they fertilize, they cannot get back. And I can go through different other mechanisms. So yes, fertility is a big problem. But I should also say here as well, very important, 80% of women with endometriosis will go on to conceive without much problem. It's important to take it in the context. And 20% of people, of women, will suffer with endometriosis as well as fertility. And if they come early for the help, so many things can be done. We're talking about fertility preservation now. We're talking about egg freezing now. There are so many things now out there now which they can be helped with if they come early, get diagnosed, and then we can do all those things for them.
Thank you very much, Christina. Let me pull you in real quick. I mean, I'm sure you've had to deal with a lot of patients as well. Obviously, you're a clinical nurse in that regard. What is some of the most difficult challenges you feel that your patients have had to face when they come to you at first to talk about endometriosis, or perhaps not even knowing that they have that?
Well, first of all, I think is the stigma that is around women's health, and the fact that we are taught from being, young girls that it's okay, it's going to be painful, heavy menstrual bleeding is fine, you're going to, take some paracetamol and use a water bottle, and then you just get on with it. So I feel like sometimes it also depends also on the cultural background and where you're coming from, and some conversation are seen like a taboo. That people don't talk too much about that. So I think it's fundamental that there is a lot of education starting from early age for all women, and I think it should start early in school, and that should be done, and just explain what it is and what it is not normal. Because like Manuela was explaining, from 10 years old she has experienced that, and she was having a period as early as 10, and actually, nothing was done about that. She had somebody that would know better, she could have had some help sooner rather than later. But just people around her being I don't want to say educated, but would have had known better. She would have had some guidance. If school had systems in place where young kids could go and speak to the school nurse and have information firsthand, like not the Google information, because Dr. Google is very dangerous, but specialist guidance and advice.
Right.
It would have made it so much better. So I think that's the first thing, the first challenge. When it comes to more adult patient that we see, I think the challenge is, as she said, being believed, because endometriosis is not a visible disease. It's not like a physical damage that you can see. Is not something that you wear a badge and say, well, I got endometriosis. No one can see it, and most people won't understand. Even between women, we don't understand, because some women, they go on every month and they're fine. Some women, they're affected by endometriosis, and if you don't go through that, you can sympathize up to a certain extent, but you don't necessarily understand the whole extent of it. On the other thing, one thing that I wanted to add on what Dr. Amer was saying about the pain diary, it is really, really helpful. There is a big charity in the UK, it's called Endometriosis UK, and is very, very vocal and very, very present. It's run by volunteers. They're all patients that had gone through endometriosis themselves, and they made it their mission to create this group. And it's a really big supporting group. They have a branch in London and in all the other UK cities. They organize meetings, they offer support to women that are going through the same experiences. And if you go on their website, apart from being in touch with them and being able to, get information firsthand, specialist information, you can also download a pain diary. There is a pro forma that they have, and you can use it. So women out there, if you want to, if it's something you're interested into and you want to know more, first of all, you can contact Endometriosis UK. Second, you can use the information, that's leaflets, pain diary that you could use. And it's a very powerful tool. When you go to your GP and you want a consultation, make sure you have everything written down, because the consultation can sometimes be a bit squashed. There is a lot of time constraint. This is another challenge that we go through as healthcare workers. We do have a very limited time that we allocated for each patient. Sometimes we only have as much as 20 to 30 minutes for a consultation, and we have a list of 30 people to see in an afternoon. And things can get missed from both sides. So if you come to a consultation and you're actually written down your symptoms and what is it that is bothering you and what you want to ask, it will make you feel like you've gone through the consultation and you got out of it as much as you wanted. So the consultation has the best outcome for yourself, and the clinician as well understands what is it that it needs to be addressed, because then you come with a clear idea. Sometimes some women, they get overwhelmed with the consultation, and you ask them question, they don't really know the answer, and they have been struggling so much, so it becomes more difficult.
Right.
So in that perspective, absolutely. So I think, yeah, so it's fundamental, and also to understand, you know, as I'm not sure about Chelsea, but I can tell you, in our services at Imperial, their waiting list is really, really long. And I think we're becoming better and better than escalating this disease and get them to be referred. But sometimes it does take time for the patient to be seen, because, as we said, there's not as many specialists in the disease that can see the patient and, you know, go through the treatment and diagnosing them and management plans. So we need to make sure that this consultation, they're very treasured, that we use them as the best of the capabilities, the best that we can.
Right, right. Manu, you obviously you work in a borough, and you do extensive work in trying to raise awareness of endometriosis. First of all, let me congratulate you for that. But you know, there's always, you know, advocacy to change things, right? You know, I like to look at politics sometimes, and sometimes in politics they would say you can't change everything overnight, right? Like you got to you got to change things step by step. If you had the magic wand to change one thing right now, right? What would you want to change? What do you think should change currently in the near future, and how endometriosis is being viewed in society, or how it's being treated? What would you want to change?
But first of all, I would love it for everyone to have access to specialists and the treatment as well. So and I have to raise up my voice for that, because I don't want, you know, I don't really want women to go privately for consultancy, because it's quite expensive.
Right.
And that's myself as well. So right now there is a big gap between NHS and private clinician.
Sector, yeah.
Yeah, exactly. So, and when I say it's quite expensive, it's not just you going to the specialist talking about it and that's it. So you have to go over and over again. So you have to see how your condition it's going, and you probably need to have another surgery. And I don't want to talk about, you know, how much it costs surgery to take out of.
I'm sure that could be very
it's really extremely expensive. So I was quite lucky that one positive things that I was going through the NHS, it was I didn't go privately, but I have to wait for a long time before I had, you know, my laparoscopy. So yeah, I really want, you know, to women to have access through the NHS in a very quicker than it looks like right now.
But you know, sorry, but that's earlier. Mr. Razal, you'd actually mentioned, or was it you or Christina who mentioned earlier that endometriosis is as prevalent as was it diabetes?
Yes.
What? Yeah. Yep. So if it is so prevalent, like why is it so difficult to? First of all, I will say this. You know, from my little, you know, ignorant point of view, there's not a lot of awareness about it. So that's one thing that I feel needs to definitely change. But for those who are doing the research and you know, analyzing data, you know, you said that it is just as prevalent as hepatitis or diabetes. Then why shouldn't you know, there be some form of focus on providing adequate, you know, urgent treatment for that or support for that? Christina, do you want to jump on it? Yeah.
On that note, and endometriosis has become one of the priority for the NHS England 10 years plan, if I'm not mistaken. I don't know if that's the correct name. So there is a project that is aiming to reduce the time of diagnosis of endometriosis from 7 to 8 years to, I think it's 3 years by 2025 and like 1.5 to 2 years by 2030. Whether that's going to be achievable, I'm not sure, but there is movement and there is awareness and there is a lot that's going to be done and is being done behind closed doors to make sure that things change. as everything in the NHS, it all depends on funds and money and, making arrangements, make sure that things are actually in place. So, but there is focus, and things have been shifting in the past couple of years, definitely.
Well, I mean, it made it better, because with all the figures that I'm hearing and all that, what's being discussed today,
Yeah.
it begs the
On
question,
the
why
other
not?
thing, I just wanted to mention as well, for all those women that are wondering whether there is an endometriosis specialist center around them, because all the patients, they get referred to specialist center, but not every hospital is accredited to be an endometriosis specialist center. So there is this society, it's a BSGE, it's British Society for Gynecological Endoscopy, and every center that treats endometriosis needs to be accredited by the BSGE, meaning that you have a specialist surgeon for endometriosis in place, especially clinical nurse specialist for endometriosis, and you can provide all the treatments for endometriosis. Now, women, they can do a bit of research on the website, and there is a section where you can put your postcode, and it shows you all the centers that are around you. So when it comes to having a look around and see whether you do have a center close to you and you like your GP to be referred to, they can take matter into their hands. They can actually look into that as well. And there is also a lot of resources for patients on the BSGE website, as well as every center that is accredited by the BSGE. We do all have a database. It's a gigantic database where all the patients' details in regards to their disease and the surgery they've gone through get inputted in. So there is this database, and they're able to analyze data and see how effective or non-effective the treatments are. As a matter of fact, the patient they're on the database, they do have their follow-up 6, 12, and 24 months after the treatments. And we do use a questionnaire that is similar to the pain questionnaire that the pain diary that Mr. Raza was describing earlier, where we go through all the symptoms and the quality of life and all sorts of stuff. And we are able to assess whether the treatment has been successful or not, and whether there is anything that we need to do as a follow-up. So there is a lot behind the treatment and the management of patients with endometriosis, whether it's complex or not complex disease. So don't get discouraged. You just need to fall into the right center, into the right place. And you can actually look for the right place around you, and you have the resources out there. It's just raising awareness on how to find these resources, really.
Right. Well, thank you about that. I want to quickly just, obviously jump into another subject, which is still commonly related. We're talking about women's health today. If you're just joining us, this is the Brand Health Matters Hour on the Beat London 103.6. We have these conversations every last Wednesday of the month. And then today we're talking about women's health. We've been talking with Mr. Amir Razar, with Christina and Manu about endometriosis. Mr. Razar, I want to talk a bit about cervical cancer, because that also seems to be something that is quite prevalent amongst women. Do you mind talking to me about that, and explain, what are some of the symptoms and how does the screening program help to identify this?
Sorry, I missed the early part of your question, Douglas. Can you please repeat early part of your question?
Yes, I was really just, I want you to just tell us more about cervical cancer. What are some of the signs and symptoms that women should be paying attention to?
Which cancer?
Cervical.
Oh, that's for no.
Oh, I'm sorry about that.
Yeah. My line is not very good sometimes.
No, it's fine. It's fine.
Yeah, the cervical cancer absolutely is one of the common cancer. We are lucky now that cervical cancer numbers are in real terms falling after a long time, right. And that possibly credit goes to human papilloma virus vaccine, which is now given to all the young girls in the schools. So I will say, whoever is listening, if you have a daughter in school, they're all offered at the age of 11, 12, and 13 to have HPV vaccine. This vaccine is absolutely amazing, very safe, and all children are given this in the school, and it protects them from human papilloma virus. Why? Because it is the human papilloma virus which then goes on to infect the cervical cells, where they can change into cancer cells. So the whole process starts from HPV infection to start with, which is quite common. Now, HPV once happens, it can lead to cervical cancer. The cervical cancer screening program actually allows women from the age of 25 to go to their GP, and all women are called by letter, invited by letter to come to GP surgery to have a cervical smear or pap smear, by which they have a speculum examination and some cells are taken from the cervix and they are put under the microscope to look for their abnormality, and HPV is also checked, human papilloma virus. If the smear test and HPV is negative, then they're called every 3 years from there on until the late part of their age. And if there is any abnormality in that cervical smear, then they're asked to go to see a colposcopist in the clinic. Colposcopy means it's a machine by which we can look at the cervix and making the abnormal cells much larger and clearer. So basically, the screening program of cervical cancer starts, number 1, from having vaccination from early age. Number 2, having cervical smear from the age of 25 when you're invited by your GP to go and have a cervical smear. Please do not miss that. We have different strains of cervical cancer. Some of them are very slowly progressing, but some of them are quite rapidly progressing. So if you do not go for smear tests regularly or miss out the appointment, that can have serious implication if sadly anybody is ever diagnosed with cervical cancer. Once the cervical smear is done, if it comes back with abnormal smear, it never means that you have cancer. Absolutely not. It just means there are some abnormal cell which a doctor need to look at with the help of a camera and make sure that these are only early benign cells, which either can be then followed up by further colposcopies, mean a camera assessment, until they go back to normal, or if they are more abnormal cell in a more higher category, then these can simply be removed in the outpatient clinic by a trained specialist. So this screening program, vaccine, saves lives. So I will suggest everybody to please attend it regularly.
Now, just to be clear, you had mentioned that the test should be done every 3 years?
Correct.
The screening, right? Every 3 years,
invited,
right?
Absolutely. All GPs are asked to invite all the patients, not patients, but all the women to come for this cervical screening program. Yes.
Now, are there any steps or life changes, habits that women should change to prevent cervical cancer or any of such? Are there anything that they can do to prevent having that?
Yeah, I mean that'd be. I mean, the one thing, prevention. The vaccine is the best solution.
Yes, that's one. But I mean, like I'm going as far as some people will say. I mean, not for cervical cancer now, but sometimes some people might say nutrition might be a helpful way, or exercising or whatnot. I don't know. I'm just really asking.
Virus, yes. Right. So virus, which is causing it actually, comes from person A to B to C by genital contact. And this genital contact doesn't have to penetration. It's just simply genital contact, and the body fluids at that level sometimes can transmit the virus. So again, that's something, a good healthy hygiene, a good healthy sex life is always good as well to help. Nutrition, good healthy lifestyle, it always improves immunity and helps us to fend off the viruses. Again, in this case, virus is the main cause why we're having this. So all these general health things do help, but basically it's vaccine, it's a good healthy lifestyle that definitely have a positive impact on reducing the risk of having this cancer.
Can UTI lead to cervical cancer?
No, UTI has urinary tract infection have no relation with cervical cancer.
Even when not treated, yeah?
Even when not treated, it's a human papilloma virus. 99.99%. That's the cause of cervical cancer.
Okay. There's a lot of myth going around that, misinformation that's going around probably in small communities where people just say all sorts of stuff. But it's really amazing to have experts like yourself explain all of this. Christina, just before we go, I know we have 6 minutes left. You quickly touched on fibroid, and I know you and Dr. Emma will probably have a lot of experience for there. But for the listeners, I really want to point. I would like you just to give me like guidelines to what women should look out for, and Doc, you probably might help out here. What women should look out for if they suspect that they have fibroid. How can they check themselves?
Okay, so as anything, most of the time, women, they can go on for many years in life and having fibroids and not knowing. In other instances, there is no self-assessment, such as women, they're taught how to do breast assessment, for example, to check for lymph nodes and swelling and stuff. There's no such a thing with fibroids, because obviously they live in the lining of the womb. So there's no way for a woman to assess physically if they have fibroids. However, if any woman that is experiencing heavy menstrual bleeding, sometimes can be caused by fibroids. Painful periods, periods that cause you to have flooding, changing your pads every 1 or 2 hours, soaking through your clothes, passing blood clots. Sometimes there can be signs for having uterine fibroids, really. If you're having pressure symptoms, such as you're feeling pressure in your bladder, you go to the urine to pass urine quite frequently, that means there could be some fibroids that could be sitting on the bladder and causing some pressure. If you have bowel pressure as well, at the same time, you have urgency to go to the bathroom, urgency opening your bowels, that can mean sometimes that you might as well have some fibroids sitting on, pushing on the other structures of the abdomen. Some women, they experience a lot of bloatness and increased circumference of the abdomen, and they feel like they're swelling up. It's one interesting thing that I found really fascinating when I started the job. It's like they measure the size of the uterus as in the woman is pregnant, so the doctor can do a physical assessment and say, well, actually the uterine size is a 20-week size. So Mr. Raza knows better than me. So it means that the uterus inside has grown so much with the fibroids that is now as big as it would be if the woman was pregnant with 20 weeks, by 20 weeks. So they can look out for signs and symptoms of fibroids in that perspective. There is not a way for them to actually feel the fibroids. Some women, they're able to, if they palpate the uterus and they know their body really, really well, they can tell whether they can feel it. Some fibroids, they're quite big. They can be up to like 10, 12, 15 centimeters for a single fibroid. If the woman is particularly slim, they can feel it themselves, but it's quite difficult, and most of the time you don't know what kind of what part of the anatomy you're touching. So in that perspective, there's not some sort of physical examination they could be doing. It's more watching out for the symptoms, like and one of the main symptoms can be heavy menstrual bleeding and pressure symptoms on the bowel and the bladder.
Okay, well we're gonna have to leave it there real quick. I want to thank you all for this amazing conversation. Dr. Razar, and like I said, I mean, I think how do I summarize this? Because, prior to going into this conversation, I knew nothing about endometriosis, and I have a daughter, and you see people complain about their menses, their periods, or have certain complaints. And we all take it for granted, right? And everybody just overlooks it. And the first thing that comes to mind is, oh, pop a pill, take a painkiller. But I think, I guess from my point of view, where I'm coming from, is I think the first thing is, once you notice a persistent sort of abnormalities in your life, just generally go and get yourself checked out. That's just the summary of it. I come from a community where we don't necessarily like going to the hospital. We just don't really like going to the hospital. But it is important that we actually do, and you lovely people have kind of made that very clear. I want to thank everybody for being part of this. Dr. Razar, thank you so much for joining us. Christina, thank you very much.
Thank you so much for having me.
I think, Douglas, we should say thank you to you as well, and your whole team, Gavin, Ivor, and this radio station, to bring up this such a critical topic to so many people. So thank you very much for giving us the opportunity to come to you. Thank you.
Blessing. Manu, thank you very much. And Manu, listen, keep up the good fight. Like, I appreciate what you're doing a great deal.
I really do. Actually, I do look after women by giving them free workshops for, in order for them to come and release, feelings. Amazing. At least mentally feelings.
Okay, so why don't you tell me where do you do this? Why don't you just give us the address, or just how can people contact you for that?
Right, if you Google Manuzart, it's Manu, MANU 'SM art. So you will find, my website, and you can see what's going on. every time I do have, a free workshop for women to take part of. And
Fantastic.
please, more awareness in schools. That's what we need, at least, once a year.
Fantastic. To wrap it up real quick, Christina, you talked about help centers for endometriosis. Do you want to just mention some of them that people you mentioned that earlier, how people can go and locate health centers online?
Yeah, absolutely. Yes, if you go on the BSGE website and you go BSGE Endometriosis Endo Center, and then there's a section where you can put your postcode, and then you can follow all, you can find all of the endometriosis specialist center in the UK, and you can just find the one that is the closest to you. Absolutely.
Okay, well, we're going to leave it here. Thank you very much, all. And for those who will listen, I hope this conversation has been, insightful to you. We're going to have another conversation at the end of this coming month, December, next month, right? Which is around the corner. So yeah, like I said, every last Wednesday of the month, that's when we have the Brand Health Matters Hour. All right. Until then, have yourselves a wonderful week ahead and enjoy the weekend coming forward. Good night, everybody.